Hello and welcome to this edition of Rural Doctors. In this program we visit PMH and talk to the acquired brain injury rehab team about a quite unique case involving a young Indigenous man from a remote community. The case is interesting not only because of the rare clinical presentation, but also because of the geographic and cultural barriers that are having to be addressed in order to provide appropriate rehab, but also consider a return home to remote Western Australia. Dr. Olga Ward spoke to paediatrician Dr. Kate Langdon, OT Jacqui Hunt and social worker Kat Broad.
Ladies, welcome to the program.
Thank you very much.
Today we have an unusual program with a case history that we're exploring in a great deal of detail. It's quite an unusual case. Kate, perhaps you could give us some details about this patient.
Yeah, the young man, JB, is an Indigenous boy who came to Princess Margaret Hospital in late January, which is the wet season up north, and he presented with a history of headache for a couple of days and vomiting for 2 days, but he was very ataxic, and which means you can't walk. So he had to come into hospital with 2 people supporting him. And was then investigated from that point onwards.
Did he actually come into Princess Margaret, or did he go?
He presented initially to Jiggalong. He was living up there. He's a young man who comes from Aluna but was living up in Jiggalong in order to sort of escape some of the social circumstances that he found himself in. The policeman, I think, had wanted him to stop solvent abusing, so he was living up there in somewhat protected circumstances, but became unwell. Saw the GP up there, who then realised there was something serious going on and sent him down to PMH for investigations. So, you know, he came in able to communicate quite well verbally, and his Glasgow Coma score is about 13 to 15, so he's quite aware, and he was clearly quite unwell and had MRI scans and a lot of investigations by the evening, and it was clear that he had a mass lesion and hydrocephalus, and immediately kind of proceeded to having a ventricular drain put in and a CSF sample taken. And it was the working diagnosis at that stage was that he had probably some infiltrative mass, probably tumour, but some kind of maybe demyelinating condition, and low down the list was some kind of encephalitis, either toxic or perhaps infective. But the working diagnosis changed over the next couple of days. He became increasingly unwell. Became apparent too that he was developing cranial nerve signs as well. He had eyes deviated to the left, he had a left-sided facial droop, and his ataxia got much worse. And by a couple of days later, he was had a reduction in his conscious level, he'd had seizures, he had spastic paraparesis down one side of his body, and he was so ataxic, he was his truncal ataxia had really sort of significantly got worse, and his communication was reduced down to sort of thumbs up, thumbs down. He was no longer able to articulate anything, and by that point there was a real need to get a definitive diagnosis. So a biopsy was done through a suboccipital craniotomy, and so a biopsy was taken, and by sort of day 5, 6 a diagnosis of myelioidosis, or in fact neuromyelioidosis, was able to be made, and the kind of antibiotic therapies commenced, but also other medications that were probably not helping were able to be ceased.
Okay, now neuromyelioidosis isn't a kind of a general practice up the front diagnosis, obviously. Yeah. It's a tropical disease. Is this an arthropod-borne?
It is
bacterial or viral? It's
a gram-negative bacillus. It's found in soils and groundwater. It's endemic in the northern parts of Australia, and such that some of the serological testing is hard to interpret because you don't know if people have been exposed before or recently. And I think, and obviously more common in the wet season. But so, you know, he's typical for that, having presented in January. But the difficulty is, is that it's an intracellular organism and can actually survive and have a fun time in phagocytes and neutrophils. And I think the cell-mediated response that it requires tends to cause a lot of tissue destruction, which is something that we've learnt by experience in a way, so that the areas of his brain that have been affected, have had quite a long, prolonged period of sort of rehabilitation around them, which I can go into. But most people who get myelioidosis, only about less than 5% or about 5% would have neuromyelioidosis, and out of all the people that get myelioidosis affecting multiple organs of the body, only about 5% are children. So it's mostly adults and 5% children, mostly multi-organ, 5% brain.
So very difficult diagnosis.
Yeah.
Is this something that responds to antibiotics quickly?
You need IV antibiotics, or someone with neuromyelioidosis needs the kind of meropenem or imipenem type antibiotics for a good 2 weeks, and then onwards for...
On the shelf in every rural nursing post?
Quite right. And then 6 months of cotrimoxazole. But I mean, I'm not an expert in the treatment of myelioidosis, but that is what he has had, and we expect to keep him on that treatment. He will have at least a cotrimoxazole for 6 months. And he still now has a small ring lesion in one of his cerebral peduncles. There's no overt signs of that. He's quite well in himself and he doesn't have fevers, but we need to be mindful of that. I mean, he should not, I'd like to send him home without any kind of MRI signs of his condition. Mm-hmm.
So this is something that you're not quite sure whether the bacteria are still active in the lesion?
Yes, that's right. Not exactly. We're not exactly sure about that.
Mm-hmm. This sounds like he must have been quite unwell and perhaps in intensive care for a little while?
You're quite right. He did need to go in and out of intensive care as his conscious level fluctuated, and also he, after having walked in, he then got to the point where he couldn't manage his airway from time to time. So he really got a lot sicker. He also had involvement of various other organs as well. He had aspiration pneumonia, ileus, intussusception. He had all sorts of other things, abnormal liver function tests, all of which have kind of resolved. He was on TPN and then he was on nasojejunal feeds. That all kind of went away. But our involvement in the ABI team started up in mid-February when we were asked to see him. The issue being that he was no longer able to communicate, and we couldn't... So
this is about week 6
Yes,
yeah?
Not so much, probably 2.5.
Oh, okay.
So quite, we had an attenuated early involvement, but it was really to facilitate his communication because, he didn't know really what had happened to him, and we didn't know whether he was in pain. It was really that simple, the information that we needed to exchange with him. And also there were other... the physiotherapists were involved, admittedly with some difficulty initially because he wasn't able to do much, but to prevent complications, keep him moving a little bit, and looking forward to recovery eventually. Always you need to kind of make sure that contracture and consequences don't occur that you can't do anything with later once they've occurred. You kind of, it seems kind of silly to be addressing those things when someone's still very, very unwell, but if you leave it until someone's better, then it's often too late and you end up with contracture and all sorts of musculoskeletal complications that are actually very hard to deal with and really impact on function. So very quietly you need to send the team in to just make sure those things are ticking over and cross your fingers that a recovery is going to happen.
In that case, who are the team? And who gets involved when doing what? Right.
So the teams that were already involved were clearly neurology and some other specialist teams. They invited the acquired brain injury team to take part. And this is a very large, it was quite a large multidisciplinary team because regrettably we do see a lot of traumatic brain injury in the state one way or another, and we also look after kids with tumours and infectious disease as well, and strokes. But the team consists of a sort of therapy component, physiotherapy, OTs, speech pathology, also dietetics come on board, and there's a psychosocial component as well. So there's a social work with psychology, clinical psychology aspect, plus then also vocational and school component as well. So we've got the hospital school services have a liaison teacher that we utilise, a neuropsych as well, with an overarching liaison nurse and community mental health nurse, plus consultants as well.
So, Jacqui, tell me how you began to be involved with this case and the kinds of therapeutic interventions that you had to make.
Yeah, right from the very beginning we were trying to work out what JB was aware of and how much he was taking in from the environment, because he certainly wasn't giving anything back, because he had no, even his eye gaze was difficult at first. He couldn't open his eyelids, so for a while there our only communication was us holding up his eyes and him being able to look around to answer questions. But from the very beginning, it's just sort of that innate feeling that you get, that he's in there and he's quite cognitively aware but unable to express that in any way. And retrospectively now we see that that was correct, and JB can remember those early days quite well, and he remembers us standing by the bedside and asking simple yes-no type questions. So communication, from my perspective as an OT and the speech pathologist perspective, we worked very closely, because there was nothing simple about anything that JB did in those early days. So even initially there was sort of no tone in any of his limbs. He had very flaccid limbs, both upper limbs and lower limbs, so to try and get some meaningful kind of contact with us was really working on return of function of upper limbs and lower limbs. And as was said before, he had a thumbs up for yes, and even thumbs down, though once he'd been through the worst processes of his illness, thumbs down wasn't even possible because of praxis issues. So the first thing was flat palm. And we progressed fairly quickly to the very nice day, but it wasn't till mid-April that JB actually could express himself fully. So that was down in OT, and it was literally me sitting there typing for him, and we went through every letter of the alphabet for him, saying yes or no, and he spelt out a sentence of "I want to go home to Aluna," which is what we all thought was in there, and we all knew that there was that opinion and that he had that cognitive function to be able to say something. But up until, so that's months down the track before he actually got to say what it was he wanted and how he was feeling.
Well, let's go and meet JB and his speech pathologist, Jerome.
All right, JB, we need to update our footy tips from the weekend. So, do you remember how many tips did you get for last round?
JB's been quite an interesting case for us, luckily a rare one, because it's obviously been a difficult road for him in his recovery. So from a speech pathology point of view, I've been involved with JB right from the early days, from when he came out of ICU, because we did have some awareness that he wasn't able to communicate. So it was really important to find a way that he could be able to talk to the staff around him and let us know how he's feeling or what his concerns were, because it was a very scary and difficult time for him. And we were also looking at his swallow safety and managing his ability to move from a nasogastric tube to being able to be orally fed. So the things that concerned us the most was his inability to communicate. We could tell that there was some comprehension going on, but he was not able to talk, he was not able to move, he was not able to sign or to show us what he felt. So the first things we were able to do was realise that he could use eye blinking to communicate to us. So our role was being able to then mould that into a communication system where he could let us know, or at least get a yes/no response from him, so that he could have a bit of say in his cares and understand what was happening to him. And we then were able to move that to eye gaze, so using an eye gaze board where he could make decisions based on choices given to him. We've also used, when he did start to get some communication, he could do thumbs up and fingers out for no. So for a few weeks we could use that for yes, no, and we managed to then start developing a signing system with him. It's been a very slow process setting up these systems with JB. So probably for the first 2 or 3 months, all he could really do was blink and use eye gaze. So it was quite an intensive time to try and help him with his communication. But around about the 3-month mark, he really started to make gains. And that's when he started getting a bit of movement back, so we could transform that movement into communication, like with the signing and being able to access an iPad with a mounting system and that for him. So that was really a turning point, I think, when he realised that he had a bit more power over his communication as well. And really the last couple months has been when he started getting his speech back, and although he's quite dysarthric, we've been able to work on his intelligibility and get him using more sentences, rather than he does rely a lot on gesture and pointing. So it has been a very long process, and it's quite it's quite a unique case because we often don't go through so many different processes with a patient, whereas he really has had everything from no communication, being locked in, to now being able to talk and being a communicator. So it has been over quite a few months, but very, very slow to begin with.
So JB, do you remember what game was on Friday night?
Good.
Yep. And who did they play?
Richmond.
And what happened in that game?
Cox got knocked out.
Yeah, he did. He did. Cox got knocked out. And I found an article on the internet yesterday from the guy that knocked him out. Do you remember? Do you know what his name is?
No.
No, I didn't know if you would. His name's Ty Vickery.
So I guess our aims now is to continue to get him to vocalise using his voice, and that's his preferred method of communicating. But because he is quite dysarthric, he can be tricky to understand at times. And he's also missing a bit of what we call self-monitoring. So sometimes he might yawn or start to slur his words and he doesn't really notice that people haven't understood him. So our aims are to get him to be more of a successful communicator, because all he wants to do is be back at home with his mates and with his family, and we want to make sure that he can be a part of that without having any issues with not being understood. And we're also trying to progress his feeding as well. At the moment he can eat normal food, but thin fluids are still an issue for him due to the nature of the lesions in his brainstem, and that he does have a dysphagia and he does struggle with thin fluids. So we're hoping more swallow rehab will help him to be able to have normal drinks when he goes home.
All right. Can I ask you some questions? How do you reckon Ty Vickery's feeling? You can get your yawn out.
I don't know.
How do you think he feels about what happened to Cox?
Bad.
You reckon he feels bad about it?
Bad.
A bit sad? Yeah, I reckon he probably does.
I guess from my perspective, this case has been unusual and quite a difficult one, given that JB is from such a remote area, and given that, you know, he is Aboriginal, and unfortunately being in a big city and the resources we have here haven't always been appropriate for him. So for someone that's gone through all the different stages of communication, being able to motivate him with activities that are of interest to him and things he'd usually do at home has been quite difficult for us. So he doesn't really enjoy being in Perth, and the sorts of things he likes doing outdoors, and we can't really recreate that here for him. So I think that in terms of his communication, it is held back a bit because of his lack of motivation for what his interests are here. Something he is very interested about is football, so that's been something we spend a lot of time talking about footy tips, and he is motivated to talk a lot and do lots of comprehension in that with it. But I think as JB gets better and better, we are getting more of an insight into his cognition and what his abilities are. So I think it's been fantastic having a really strong allied health team where we regularly meet and regularly talk to each other about working with JB and goals for him, because he is a unique case and he does need that extra time thought about how we can motivate him. And one of the important things about rehab is making sure that it's salient and motivating for the patient, or they're not going to make any gains. So I think having a team behind us where we're able to do joint sessions, so if he's interested in football, for example, we can get him to have a go at using his limbs or whatever for football-like things, and then discuss how the footy was on the weekend. So we do work very closely as a team, and I think it's really important, the regular team meetings that we've been having, to discuss his case and how we can work with his family and link things in, because rehab won't happen if he's not interested and doesn't really care about the sorts of games and activities that we would usually do here. So I think the team perspective has helped him to move on, and I think the intensity of his rehab program has also helped him to make really big gains in his time here. And again, he's so far from home, so he doesn't always get the visitors, and his friends and that coming in that other children usually would. So I think having the intensive timetable and finding other ways he can connect, like using Facebook and helping him to access that, has been an important way that as a team we've been able to keep him committed to therapy and rehab, which has made a difference.
What do you think will happen to Ty Vickery now? How long do you reckon for?
1 year.
A year? Really?
Jacqui and Kate, it looks like it was quite a difficult task to develop speech and communication, and obviously this goes hand in hand with all of the other rehab things that were happening for JB. Could you maybe talk us through some of the other rehab issues that you had in those early therapy days when you're trying to develop some motor function and some fine hand function and work out what's going to be, is rehabilitatable a word?
Well, there is no set path for recovery in an acquired brain injury, and JB certainly didn't show us a set path either. And there were certain times where we'd be taken aback by sudden progress. So he certainly started to move all of his limbs a little bit more, but was showing more of left side involvement. So he was still, up until probably a month or so ago, he was still only not, he wasn't using his left arm well for function at all. His right arm was getting there, but had a lot of intention tremor, so his independent use of that hand for anything, for eating or for typing, communication, for any kind of mobility, there was still quite a tremor there, so it wasn't very functional at all. But then literally overnight, as he was all set to have Botox on his left upper limb, he literally regained movement and started to use that hand as well, but still not very functionally.
Is this something to do with the neuroplasticity of a young person, or is it more to do with sudden reduction in swelling, or what do you think causes these big jumps?
Well, I think it's really hard to say whether it was the improvement in the infection, the cerebral edema, he basically had loci of involvement right throughout the white matter, both cerebellum and through the cerebrum. So I think it was a reduction in infection, but also coupled with the training and rehabilitation efforts that had gone in. I think, it was difficult to know how many times you would have to repeat an exercise or a task for it to sort of sink in and for him to make progress. And also we don't know where we're aiming for because we've not treated anyone with this condition before. Yeah. So I think part of your art was to persist in offering him challenging activities to do, and ones that were culturally appropriate and ones that he enjoyed and ones that stimulated him. And so it's hard to know exactly why he improved, whether it was the sort of rehabilitation finally taking hold and the neuroplasticity, or whether it was also part of his reconditioning, recovery from the infection, or all of the above.
Yeah. Now, you've talked a bit about his MRI scans, which I gather must have looked pretty horrendous to start with. How often do you need to rescan something?
There was a long gap. We basically had a 2.5-month gap between the final MRI scan that was done at the end of March. Those scans really had quite global involvement, and with but more recently we've just done one only about a month ago, and there's now gliotic changes in the cerebellum, particularly on the left-hand side, which was the area that was first involved when he presented. There are still there's still a ring lesion in one of the cerebral peduncles. So we'll keep an eye on that. But you can see that he also had quite significant involvement through the basal ganglia, through the brainstem with these cranial nerve signs, and in the right periventricular areas as well. But it's quite extensive involvement, and you can see tiny ring lesions throughout his MRI, certainly at its worst back in sort of February, early March, largely most of which has now resolved.
Okay, so if this has involved his basal ganglia, is he likely to get any recovery there, or are you looking at long-term ataxia and Parkinsonian things.
Yeah.
How do you deal with that?
It's a good question. We don't really know how much improvement we can really see in terms of his overall ataxia. And
I guess you won't know how much to expect with something this unknown.
And it's one of the things that's most important for him to recover as well as he can. There's probably a few things contributing to his gross motor issues: visual problems, vestibular problems, possibly from brainstem involvement, basal ganglia, cerebellum, and also the kind of more peripheral involvement, or the spasticity that we've seen in the left-hand side of his body in particular. So we're certainly crossing our finger with the basal ganglia involvement. He's on Cinemet, which is really helping him. He has a kind of Parkinsonian aspect to his presentation. We tried to reduce it a week or so ago without a good effect resulting. It's had to be reintroduced back to its full dose, and we've seen such a good recovery. We sort of know, don't go there. He's much better at initiating movements. He's smoother and much better in the pool. And I think the session today showed that he was actually much better at standing and weight bearing. So it seems to treat the bradykinesia and akathisia that he's had, and the difficulty initiating even speech, and his flat affect.
So, ladies, where are we at now with JB? Can you give me a snapshot of what his clinical picture is at the moment?
We thought the best way to do that was to use the WeFem, which is a functional measure that we use within the service to work out where our patients are. There is an adult version of this, but in the childhood version, really the ceiling measure, a score of 126, is what a 7-year-old who's independent can actually do, and it measures different...
So that's your best function?
Your best function.
Yeah.
And JB, when he was at his worst, was scoring 1. He was completely dependent for all his ADLs, and now he's somewhere in the middle at about 47. But he's making great progress. I want to make sure that you know that this is not a plateau. But I think it would be useful to find out from Jacqui what the scores really entail.
It obviously encompasses a lot about the physical function and how that translates to functional abilities. And he definitely is still making progress, so it's really nice to see. But it's kind of at that stage where you think, how much do we compensate and how much is there still improvement happening? So
you're scoring on things like able to pick up a spoon and feed self, able to comb hair, that kind of, is that what you're looking at?
Yes, yeah. And so for feeding, he is doing quite well independently. He flatly refuses any adaptive equipment, so he would do best because he still has a slight ataxia, and that right most functional limb is still not smooth and fantastic movement.
So you're a right-hander?
Yes, well, and he certainly is now, but yes, he is. So he's eating with the right hand, but no adaptive cutlery, so his plate will slide around the surface, the table surface and those sorts of things, and he's a very messy eater, but that's JB's choice, and that's what he's chosen to do. But he's certainly able to now be left with a meal and serve himself a drink, which is still thickened though, because he still has swallowing issues. And as far as mobility, again, mobility's been this back and forth. How much do we push independent mobility? So he is dependent in a manual chair, so he needs to be pushed around in a manual chair because of because of that hemi. So he's really not great using. And I think a one-sided wheelchair is quite complex to manage, and he doesn't have that really quick processing and or initiation of changing movements. So I think manual chair, self-propelling manual chair, is out of the question. So he's just trialled a power wheelchair, which was amazing, and he loved it. That was his first mobility in about 6 months, for him to actually be able to go where he wanted to go without being reliant on someone. Which for the first time we really started to see that left neglect, because he was banging into everything on the left side, but that was his first freedom in mobility to really see that functional effect of his neglect. But so that's where we're at with mobility, really looking at getting him that powered wheelchair and funding something like that for him to go home. But having said that, he's still quite heavy in transfers. So the reality of getting him in outside of the hospital at all means a transfer into that powered chair, and then a transfer in the powered chair into a wheelchair vehicle. So in the 6 odd months he's been here, he's left the hospital twice, to go once on a technical appointment and once on a family visit.
What are the other domains that you assess on the WeFM, the independent sort of measures that?
Okay, so toileting, and we do things like toileting, showering, and it's all equipment based with drudge, and certainly all supervised and assisted. There's nothing, I don't think there was very few areas that he scored highest in. Those that he did score higher in were the cognitive, it was sort of cognitively weighted, anything that required a bit more thinking, but those that required physical skills, so mobility, obviously climbing stairs was not able to be scored, toileting, showering, feeding, all of those things that require more motor input is where he scored really quite low.
Thinking about his basal ganglia, what's he like at actually thinking, I'm going to make this wheelchair move, and pushing the lever to make it go? Surprisingly good.
Yeah, surprisingly good. I think but the more motor involvement you require, so just that small motor involvement is good, but the bigger movements, so initiating, say, if he's slipped down in his chair, just to reposition himself, the initiation there is quite slow and he won't actually sort of initiate that himself. You have to say, now look at how you're sitting, how can we get you up? And even to get him up, it's still breaking that right down to say, okay, lean forward, hands down, push back. It's not a smooth action for JB at all.
Well, let's just go back and see what JB has been doing in terms of physiotherapy and movement initiation and improving balance.
JB presented to us initially with a very severe ABI as a result of neuromyeliodosis, which resulted in him having inability to move his arms and legs and his body, and he was quite unwell and bedbound initially for quite a long time. It took about 3 or 4 weeks from his initial presentation before the physio team got involved and were able to start getting him up and moving. And initially that involved the use of a hoist to get him out of bed into a wheelchair. And we also used a tilt table to help start transitioning him from supine up to an upright posture. That took several months of that kind of therapy with a number of therapists before we could start looking at standing training in physio. So that started about 4 months after his admission. He was able to start trying to do standing practice at a rail. So he had quite significant weakness and impairment from his brain injury. He's more impaired on the left than the right, but his impairments are both very different. So the left side is very much a weakness impairment, and the right side is a coordination impairment as well as weakness. So he has different symptoms which need to be treated differently. He's had a variety of physiotherapy input, ward-based management, coming down to our gym, and recently starting hydrotherapy. So the pool is a really great environment for him to start learning to move in. It's a very controlled environment for him, but we were a bit delayed in being able to start his therapy there because of other medical issues, such as his continence and swallow safety. So that's only been going for about 3 weeks now, and he's already showing really good improvement with his ability to step and start gait training on land as a result of the work he's doing in the pool. There's the physios, the occupational therapists and the speech therapists, and we often work as a team in joint sessions to try and facilitate the goals for patients like JB to achieve. Because of issues like fatigue and just the number of therapies that are required, we do a lot of joint sessions, and we have to do a lot of planning in advance for how his week is going to look. So each week we sit down and plan his therapy timetable so we can make sure we're including all of his needs in the week that's upcoming, and we discuss what the highest priority for the week ahead is so that can be met, and we talk to JB about what his priorities are as well and how he wants us to incorporate that into his week. This week coming up, we're starting serial casting for his feet, which has taken a lot of coordination between all the therapists, the medical staff and the nursing staff. The goal of that is to increase the range in JB's ankles so that that will improve his standing and his walking, and basically involves casting both feet in plaster casts to give him a prolonged stretch. So they need to be changed twice a week, and trying to tie that in with his ability to still do hydrotherapy and all his other therapies, and it turns out to be quite a busy week, so scheduling in advance is really important. But also often therapists work towards the same sort of goals, and by being aware of each other's priorities and goals, we can incorporate that into each of our sessions. So we would often do a session with the occupational therapist, look at seating and transfers and positioning, and the speech therapists also get involved with us.
All right. Jump around the bed and do all kinds of things like that. Yeah, they do. Do you want it that way?
He has come a very long way to where he is now. He's now transferring with one, sometimes two people in and out of the chair and the bed. He can sit to stand to a rail with the assist of one person, and he's just started gait training in physio with the assistance of two people. The gait training is really, really hard work, and whether or not he will become a functional walker is yet to be seen. The nature of his illness impacts significantly on his gross motor function, as well as his ability to plan and coordinate the movement. So we're doing a lot of work at the moment on that pre-gait training to try and work towards that. Realistically, it's a bit of an unknown. There's not many cases before this to sort of tell us what prognostically we're looking at. He has come so far to this point where he could actually start doing gait training. We didn't think he'd get to this point, so he's already surprised a lot of us, but we're probably talking another 6 to 12 months of intense rehab before we can really see whether or not he will be a functional walker. In all likelihood, he will need a power wheelchair for his outdoor mobility to be independent, because the amount of energy that walking takes from him is substantial. So even if we can get him to the point of being able to walk little bits indoors, in terms of his overall independence, we think it's probably going to be power wheelchair dependent. Obviously, to be able to go home, he needs to be able to transfer with one person at least. And he needs to be independent in some form of mobility, whether that's a wheelchair or whether that's walking little bits. The environment that he goes to will very much dictate that, and we're currently exploring where his discharge destination will be and the setup of that environment. Obviously it will need to be wheelchair accessible, but also in terms of who will be able to provide that care and how he will get ongoing therapy is a very important consideration for us. Our plan is to continue to provide intense rehab while he's an inpatient, to try and progress him to be as independent and as strong as we can. But we also play a large role in carer training, so family, friends, staff, to be able to give them the skills to be able to carry over his rehab once he leaves here, and to be able to ensure that he gets a safe discharge into the community. My hope is that he will be able to do a little bit of walking around the house in the long term, and that he will be able to cope just with a single carer rather than needing two people around, and that he will be able to access his community, his school, his family independently through use of powered mobility. But this is really a very rare case for someone with such high needs to be returning to such a remote community where there is not really anyone who's needing this kind of level of care and is this dependent. So it's very new, and it's involving coordination of a number of agencies, because we don't want him to sort of be lost to the system. We want to be able to, follow him and make sure that he continues to make gains and to settle in at home.
Sounds like it's been very complex to look after JB in a hospital. I guess the next step for him is going to be discharge, which is a very enormous step. Kat, how do you start thinking about what he can do and where he can go?
It obviously hasn't been an easy case for anyone, and one thing that when I first started to get to know JB and his family was that he has a real strength in his connection to family and country, and so being mindful of both of them as well as his functional and ongoing medical needs has been kind of the ongoing challenge. And when I first became involved, I think I actually went and saw Kate and said, look, I'm not sure where he should go. He clearly wants to go back to his hometown in Wiluna, but and we want him to be able to have that opportunity, but it's going to be a struggle. And in the background is a lot of family circumstances and cultural considerations which haven't made it easy to make some of those plans, some of which have been well outside of all of our control, and some to an extent the family as well.
So can you tell me about what would be needed to rehabilitate him, say to a major regional town or to a minor town or to a really remote community with no inpatient hospital like Wiluna? What would you need him to be able to do, and what don't you see him able to do? Or
like, I guess the first thing that we had worked out is that he needs a carer. He needs someone that's going to be an advocate for him, and not only just be able to advocate his needs, but also provide for his basic care needs. And that was the initial challenge, was that actually his guardian, his mum, wasn't able to provide a lot of that basic primary care needs, and we were observing that both in hospital, but also her circumstances of having lots of other kids to care for, and social factors that were just not really, I guess, possible for her to take on the care of someone like JB. And so that was the first thing. So
sounds like you need more than one carer.
I agree.
You're needing a few people to help him to transfer.
Yeah, in JB's situation, it's almost not a case of is he ready to go home. It's is home ready for him, because there is he with him will come a whole package of equipment and needs and plans. Because they're literally at the moment there isn't one thing that he could just, he would stay in one spot if that's where he was left. He's dependent on everyone still for every aspect of his care, and then but the problem with goal setting with someone like JB is, and I'm not sure if it's possibly age, because he's a 15-year-old boy. It's possibly
I think a lot of it's culturally. Yeah, and for setting rehab goals is completely a white fella way, and it just made it really difficult for the rehab team.
So to try and say what would you like to be able to do, and to have some investment in the goals has been really difficult, to try and get JB to invest himself in those goals. So a lot of the goals have been set by us, and have been us making what we know is going to be needed, like very practical things, like you need to be able to be toileted by someone in your family before you can go home, because otherwise you're going to sit unclean all day.
And beyond that, the getting those skills to be able to do the toileting, transferring, are very difficult. We were just going through who in the team has actually done transfers. The nursing staff are able to do them, but they're often men, and they do a fairly kind of rudimentary transfer on occasions. But in this team, the OT physios do all the transfers, but you do a lot of prompting, and you prompt every time. It's not, this skill isn't one that's getting less. It requires sort of step-by-step instructions to carry them out. And for toileting, that it's very labour intensive, and it is a 24-hour plan, or a care plan that he requires, really for pressure care amongst other things, particularly around toileting, and that he would need someone to make sure he leaves his bed in the morning, is in a chair, so that he can get around and be independent. And those, there's also feeding issues to be considered, although he's made quite a lot of improvements there. But it's a very labour-intensive day, and you can't have any breaks. If he spends a day without being adequately toileted or having his perineal area addressed properly, it could break down incredibly rapidly. We have attempted to see if we could have breaks in Kalgoorlie in various areas, just to give him an opportunity to be a bit closer to home for a while. And, it has been difficult. Even the larger centres were a bit overwhelmed by the nursing care that they would have to provide for a single patient. So we understand that we are taking someone who there is no precedence for providing the kind of care that JB requires in these, not even necessarily rural areas, but certainly not in remote areas of WA.
Yeah. So, Kat, you were talking about some of the issues that you've seen. If you were trying to, say, organise for him to go even out on a visit. What kind of cultural things have you had to address, and how many big, strong, strapping fellas do you need to transfer him off and on the loo, and how often?
From a social work perspective, I've been guided a lot by our Aboriginal liaison officers in terms of some of the cultural considerations we've had to make in preparing for his discharge home. And one of the big things that really came to fruition when I started was the family's overall need for quite a different way of communicating to start off with. They found that big family meetings were hard. They didn't necessarily understand a lot of what was being said at times, and didn't feel quite as comfortable to be able to ask questions and clarify information.
Yeah, so when you say big family meetings, have they come all the way down from Wiluna to Princess Margaret for those?
So yeah, I should tell you practically that they have, from the get-go, it's been kind of on and off here in Perth and accommodated by the hospital to provide some ongoing support to JB, who has very much, as I said, relied upon his cultural and family connections in order to keep his overall quality of life intact and his overall mental health and well-being intact. When he has been on his own here in Perth, he has, I think we've all experienced, the enormous struggle that he goes through to be motivated to attend therapy, to be motivated to do really anything in his day, and been incredibly sad. So part of my job has been very much about trying to keep him as much of a participant in his care, as well as keeping his mental health intact. Well, we've done that via arranging for family to be here as best as we can. The team have worked very hard to connect him back with social media, so he has some friends that are around that can continue to connect. But also we've been fortunate enough to be able to use our telehealth and video conferencing facilities here at the hospital, where we had weekly video conferences up to his family in Wiluna. So he could see all his siblings and all his aunties and uncles and anyone that was there, and that was a time for him and him only. It wasn't something that us as team had anything more to do with.
It wasn't a therapy thing apart from the general therapeutic effort of seeing them.
And it brought him, I think, a fair amount of pleasure in his week, and so much so that he called me a lot to ask for many more sessions. But he certainly, I think, got a lot out of that. But you spoke about some of the cultural kind of considerations, and we realised very quickly that this family need to make decisions together, and to ask his mum to make decisions for him was actually never going to work. We needed to actually get, and for this family it was the women's business. We had to get the kind of matriarchs of the family together around a table with our Aboriginal liaison officers to talk about who was actually going to care for JB. And it was, I got to sit in that room and see how that went out, and it was a lovely display of them all problem solving together, which I hadn't otherwise seen, and I think is very unique to this family and Aboriginal culture in a lot of ways. So they had decided that they needed to work together, and identified an auntie and uncle to provide that ongoing care for JB and Leonora. So that's where we got to with the family.
Okay, well, Leonora still sounds to me like a pretty big challenge, given that the Kalgoorlie Hospital found that he was going to be a very heavy nursing prospect. One auntie and one uncle, how much of a team can you pull together, and what sort of other allied health facilities and professionals can you pull in?
Well, it's early days. We'll be going through the same process we did in Wiluna and link up the professionals involved in Leonora through video conference. There is plans afoot to look at the dwelling that's already there. We're now making applications for Homes West housing. There's also a CAP application underway, but there's a need
CAP application
for funding for all his...
It's like a community...
It's a combined application process, so it's with disability services. But unfortunately, all of this takes time, and even to put in an application like this, for all his ongoing funding needs, from transport through to home modifications, through to someone to manage even the finances going on, takes months, and we won't probably see a result until the end of the year for some of that.
And ideally, we'd have him go back to school as well. So you look at the access issues around that as well, and make sure there's someone. I mean, that gives the carers an opportunity for a break as well.
Yeah. So, Jacqui, what does the OT access
Well, being this far away from home, it means that we can't pop out and do our usual discharge visit. And unfortunately, asking other rural therapists to do it, they sort of do monthly or bi-monthly visits to towns like Leonora, so that then extends obviously the hospital stay or even any plans for admission, because we still haven't seen the house. But going home with a powered chair, a manual chair, a hoist for if he's unwell, because he would then be dependent in transferring, a height adjustable electric bed, and you know those things don't fit in your average home.
Toilet seats, railings.
That's right. Possibly
hoses.
Shower commodes, modified bathroom. There won't be possibility of in bathroom transfers. It would have to be onto a commode and into the bathroom. So every aspect of that home is going to need some modifying. So we've had to be flexible.
And then ramps in the schools. And
That's right, ramps. I mean,
everywhere.
yes, the schools are supposedly accessible, but when people think accessible, they don't necessarily think a great big electric powered wheelchair. So I think that's also our challenge, and how we then work, you know, with getting all of those modifications done. None of us have wheelchair accessible cars, and he wouldn't at this stage be safely able to be transferred into a typical car. And his chair is quite complex, so even his manual chair has a tilt-in space, which then means it can't be folded up and put neatly in a trunk either. So you couldn't even transfer JB into a back seat and chuck his wheelchair in the back. So to literally get from here to anywhere at this stage is reliant.
A drive-in van.
That's right, a wheelchair van with a hoist and tie-down straps and all the rest of it. So it's
and somebody licensed to drive it.
Yeah,
that's exactly right. So there's not one aspect of it that's going to be easy or quick.
I think the challenge then also is remembering that he really loves outings. You know, he's been to the football. There are things that he would love to do. So it's quite important that wherever he does go, he can actually go out. You know, that once he's out and he's actually able to control his wheelchair, he can see well enough to go somewhere and use it, powered wheelchair. You know, there's quite a lot of capacity there. He's just has a lot of trouble with the basic gross motor function to get from here into that to get going. But actually once he's all supported in that aspect of his care, he's ready to go. We usually look after kids with the exact opposite problem. Traumatic brain injury, recovery, or the process of recovering from a traumatic brain injury is usually exactly the opposite, where the gross motor function returns first and quite well, and the physios can basically wave goodbye. And then the ongoing problems that emerge as time goes by are executive functioning and sometimes to a lesser extent cognitive problems. So there's problem with attention, memory, some language problems, but also perseveration and planning and those sorts of things. So we don't usually have the problem with not being able to send kids home because their gross motor function requires so much nursing care. And so that's just one of the reasons why we couldn't quite work out why we were sort of having difficulty problem solving around some of the things we were seeing, and it's because he represents a very atypical rehabilitation style for us, where we're all very, very labour intensive still at this point. And his cognition is where he's at his best, and in order to realise that capacity, he needs a lot of support, but it's worth doing.
Yeah.
So we're used to that sort of scenario where the parents are adjusting to a sort of a new child, as it were, but we usually have to explain a different type of new child than this new child.
And psychologically, JB is similar to other children in that he still has in his head, when you say, why don't you want to practice lower limb dressing, he'll say, because when I get home I'll do it. So he sees himself as, this is hospital JB, and when I get home that will be back to home JB, and he doesn't see that there's been that big change, which isn't that uncommon with children. They say it'll be okay when I go home, everything will be okay, which seems a very illogical thought, but I guess when this with JB, Perth and PMH and this disease has been all part and parcel, and home is something quite different. We'll just do that when I get home. And so I say, well, show me right now what you think you'll do, how you might do that, and there is no ability to do it. So that trying to help him come to terms with the fact that no, this will go with you to home, and this level of function will be even harder at home, because you won't be able to press a buzzer and someone come and help you with those all the needs that you're asking for throughout the day.
And the point we're at too now is communication is better, is that it's important for us to convey to JB what has actually happened to him and make sure that he's comprehending that. Sometimes we have to do that much earlier so kids are compliant with therapy and actually understand why the therapist appears every day. So sometimes we have to do it sooner, but now that we're able to converse so well with JB, I think it is necessary that he understands what has taken place in order for him to understand what he needs to work on.
Kat, talk a little bit more about this sort of practical aspects of trying to give a young man like this some kind of future, which is, what you guys are planning. Hopefully he'll be able to get into some kind of situation where he can attend the footy and go to school and talk to his mates on Facebook and whatever.
Yeah. I think the family have been integral in helping him have a future, because they're very much, I've learnt very quickly that they're not a family that talk about what's happening in 3 months' time or a year's time or anything like that. But the fact that they will be with him, I think, has been enough for him to feel like he's got some, future orientation, that he's got people that are going to be around him and keep him connected to his peers and his his bush and going out hunting and all the things that he wants to be able to do.
Is that going to still be possible with mum and dad and siblings in Wiluna and him in Leonora, which is still not a small distance?
No, it's not. I mean, they're the ones that, as I said, have come up with this as a solution for now. And I do think that the fact that this is a family that, despite a lot of difficulties that they've had, have actually shown a lot of resourcefulness of being able to get to and from Perth, from Wiluna to Perth. There is a lot of family in Leonora. It's not just auntie and uncle, that there is extended family that are there, and Wiluna actually doesn't sound like quite where the family are from in the first instance. It's where mum and her current partner is, and their other kids. So I get the sense that, in fact, for this family, Leonora may actually be a better base, particularly from, when we've had previous video conferences with Wiluna, it certainly became apparent that Wiluna did not have at all the resources to provide any support to that family, whereas Leonora seems to have a few more. They have a hospital at least, a small hospital, but they have that at least, and they have an accessible school and a principal who's got special ed training, and they've got a few extra things that certainly don't make us feel as worried anyway as what we were previously.
It sounds like there's some kind of solid base and somewhere for JB to go. What are we aiming for, and what's the next step in achieving that?
Right, I think we've got to re-engage with the local services up in Leonora and make sure that they're on board and able to provide what we need to get. We need to get the money to provide what needs to be there at the other end, and it needs to actually be in place.
That sounds like a large task for Kat.
Yeah.
We're a double team,
and we need to engage the family. There's kind of practical training that needs to occur, and we need to see what other resources we can get on board to support them. And where JB is concerned himself, we really want him to be as independent as possible, with evidence of that at a very fundamental level, so that he can basically move around in his environment as independently as he can, basically, so he doesn't succumb to, as we've alluded to, things as basic as pressure sores and that kind of thing, which he's still at risk of, even though he's able to Facebook his friends.
Time frame?
What would be nice is
how long is a piece of string?
Like it would be nice to see JB outside of the hospital, even if it's not straight back to Leonora. It would be nice to see him spend some time across the road at our accommodation, for example. And as silly as that sounds, that's not as easily done either, because it's not fully accessible for a big bulky power wheelchair either. But that is our goal, is to have him outside of the hospital, so that he and his family are fully responsible for his cares, and there's no call button, and there is no, because I think it's really hard to imagine life outside of the hospital, and that's not just for this one family, that's for all our families. So usually we would try a period of leave and checking back in with the hospital and how that's going before we discharge. And I think that's what we would also need to do in this case, so that there's a really clear understanding of exactly what's required and support there for the family if that's not doable.
This will be a difficult discharge if it's a long way away, just because we won't be able to provide that kind of graded return. So we're going to have to check how things are going and how cares are being provided in a very artificial environment here, not necessarily at home. We may have to be a little bit more creative and actually get people to be on, local. Some of the nursing staff upstairs are quite keen to actually go and be on site when JB is actually going home. That idea's been put forward, but we'll have to, that would require some assistance from the hospital executive, so we'll watch this space.
I guess at the moment we're asking for everything and the kitchen sink all in one at the moment, because that's the kind of thing that JB would need.
And the kitchen around it, yeah.
And yeah, pretty much everything around it. And the problem is that we're putting this up to people who, we don't, without that funding, I think we're all very concerned that JB, will not be able to really go very far at all, because he certainly needs, a hell of a lot of support, and his family also. So some of his future remains uncertain, and that's what we have to sit with as a team as well, is the anxiety that comes with not knowing what will happen to JB beyond the walls of this hospital, really, and just trying our best to prepare as best we can in, really what is unfamiliar circumstances for lots of us.
I interestingly came across a case report of a child aged 14 from Queensland who also had neuromyelioidosis, and it was really talking about other aspects of the care, but the last sentence was returned to the regional hospital was able to be discharged 6 months later. So I suspect that the scenario that we're experiencing has been experienced before, where there's this prolonged process of rehabilitation, and and the description of the functional problems that she experienced was very similar, with ataxia and gross motor issues, some behavioural, some cognitive components as well. So, I think this path has been trod before, just it hasn't been sort of described before necessarily with this particular condition. But I suspect that this very long process that we're going through is actually what we've just had to do. We've just had to do this. This is what the case has required.
And I think unanimously the team would say that our goal is quality of life for JB, and that is in remote WA. It's not here in Perth, that's for sure.
Well, thanks very much for joining us today and going through this incredibly complex case and giving us the benefit of your very wide expertise.
Thanks very much.
Well, that's all we have time for today. I hope you enjoyed that case study, and a big thank you to all of the ABI rehab team at PMH. Our next program will highlight a few more fancy tests and procedures that are now available, and it includes a discussion on advances in vascular surgery. See you then.